I'm extremely delighted and deeply honored to be here, and I'd like to express my deep thanks to the organizing committee for this terrific program and for putting this terrific program, as we have no time to blink, because if we blink it, we will lose a lot of information. So no time to blink. I'm going to shift to something new in clinical complication, clinical complication of liver cirrhosis, which is muscle cramp. On behalf of my co-authors, it is a pleasure to present here our randomized controlled trial of baclofen in the treatment of muscle cramp in patients with liver cirrhosis. First of all, the authors declare that there is no conflict of interest and there is nothing to disclose. By now, the outlines of my talk will be introduction about muscle cramp in liver cirrhosis and its pathogenesis, treatment, and do we need new drugs, why baclofen, and finally, highlights on our clinical trial. To start with, muscle cramps are defined as involuntary painful contraction at rest or during sleep of a muscle or muscle group that may last seconds to minutes and are usually self-limiting. But is muscle cramp common in patients with cirrhosis? The first report of association between cirrhosis and muscle cramp was made by Kornikov and Tudor in 1986. Of 33 patients with cirrhosis who were studied, 88% of patients were found to have experienced more than 2 muscle cramp in the calf muscle within the last week. And since this report, several subsequent studies have demonstrated a 22 to 88% prevalence of muscle cramps in patients with liver disease, depending on the differing definitions and frequency and the inclusion criteria. However, is cramps related only to diuretics? Abrams et al. Compared patients with cirrhosis and with those with congestive heart failure and found significantly higher prevalence of muscle cramp in patients with cirrhosis versus patients with congestive heart failure. Interestingly, there was no difference in diuretic use or dosing between the two groups, supporting that there are other factors in cirrhosis rather than diuretic-mediated effect explain the difference. So together, these studies suggest that there is unique physiological changes and unique pathogenesis in cirrhosis predisposing to the development of muscle cramp. However, despite this clear association of muscle cramp with liver disease, there is a paucity and few information regarding the pathogenesis and the treatment in these patients. What is about the pathogenesis of muscle cramp in liver cirrhosis? The underlying mechanism is not fully clear, but there are several theories, including changes in nerve function, changes in energy metabolism, and electrolytes and plasma volume changes. I think this diagram is perfect in this setting. The main pathogenesis may be change in nerve function in patients with muscle cirrhosis, with liver cirrhosis, or changes in the plasma volume and the electrolytes, maybe a shift of plasma volume or electrolyte loss. Also, in a change in energy metabolism in the form of decreased ATP formation concentration and decreased taurine concentration, which we will discuss in details. The first theory is the nerve dysfunction. Histological studies revealed that those patients with liver disease had thin myelinated nerve fibers and loss of axons, supporting the presence of structural damage. Nerve dysfunction in cirrhosis may be due to structural alterations and oxidative stress, leading to increased excitability of the motor neurons. Based on these theories, many treatments were proposed, like vitamin E as antioxidants, 300 milligrams 3 times daily to decrease the nerve excitability. Eperisone hydrochloride as a muscle relaxant have been shown to be effective in small studies. Quinine also have 200 milligrams twice daily. However, quinine is not recommended because of the associated risk of thrombocytopenia, hemolysis, and cardiac arrhythmia. The second theory is change in amino acid metabolism, as the liver has central role in amino acid metabolism, and modification of the amino acids and synthesis of amino acids into proteins. The main changes reflected by decreased plasma and skeletal muscle concentrations of taurine, which is the most abundant amino acid in the skeletal muscle in patients with liver cirrhosis. Based on this theory, many treatment was proposed as supplementation with taurine and some branched amino acids, which seemed to be effective based on the results of small controlled studies. Another potential contributor may be change in the energy metabolism in patients with liver cirrhosis through decrease in the ATP production, and lack of ATP could diminish the cycling process of actin and myosin, causing prolonged muscle contraction and muscle cramp.
Dr. Abd-Elsalam, I have to ask you to go directly to your results because unfortunately we have only 7 minutes and we want to see your interesting results, please.
Of course. Low blood calcium and magnesium also may contributing, shift in the plasma volume and the change in electrolytes. This diagram is perfect to summarize the pathogenesis of muscle cramp. And by now, treatment, and do we need more drugs? The potential mechanism of action to treat, the current treatment for muscle cramp include quinidine sulfate, as we said, vitamin A, human albumin, but it is with no report side effects, zinc, taurine, through the change in the amino acid, ebrysone, and branched amino acids. To summarize, there appear to be a number of promising treatments for muscle cramp in liver cirrhosis. However, there remains need for further double-blinded, randomized, controlled clinical investigations, as up till now, no well-established therapy for this complication. So why baclofen? Why we consider baclofen? Baclofen is derivative of GABA, which is a muscle relaxant, has very low liver metabolism and mainly eliminated by the kidney. Baclofen also has been used with apparent safety in treatment of other medical disorders like GERD, cluster headache, hiccups, and the cough. Recently, a small pilot study was done by Henry Dakhari, concluded that baclofen can be safe and effective alternative for treatment of muscle cramp in patients with cirrhosis, but they recommended that larger randomized placebo-controlled trial is needed. To address all these issues, we designed our study to assess the safety and efficacy of baclofen as a treatment for muscle cramp in patients with liver cirrhosis. This diagram is excellent in demonstrating our study, design. We enrolled 127 patients, 27 were excluded. 100 patients were randomized, 50 received the baclofen, and 50 received the placebo. In the baclofen-treated group, the median number of muscle cramps significantly decreased from 14 to 3 per week, and after 1 month, and then to null after 3 months, with a significant rebound increase of muscle cramp to 2 per week after the baclofen washout periods. There was no significant change in the muscle cramp frequency or severity of pain following treatment with placebo. As regard to side effect, about 8% for patients had drowsiness, 10% of patients had constipation, 2 patients had nausea, and no serious adverse event has been reported. So in conclusion, ladies and gentlemen, baclofen was well tolerated, safe, and effective in the treatment of muscle cramp in patients with liver cirrhosis. And finally, thank you.